I invite Dr. Saeed Ahmed again. I think he's going to talk about interventional nephrology again from west to east.
On this conference, which is unique almost to what I can see in the UK. There's really nothing new here, but just to show that the bridges of collaboration need to be strong, and we should have a lot of collaboration going forward. So these are my posts right now. I work in South Francis Syndrome Hospital, I'm clinical director there now. So data, I mentioned in my first talk, as we mentioned just the previous speaker as well. These are the real, just heard from the Chinese data set, that's way off the scale over here, you know, so you need to know what you're comparing to. So China, so here we are here, we're just over 100 per million population starting dialysis. So we're a small country of 65 million people and 100 per million start dialysis. But our systems are quite advanced in the sense they are tariff-based dialysis, and we're incentivized to improve vascular access, and that's what we're going to talk about. We are disincentivized to do tunnel dialysis catheters, more for the money, but also for the morbidity. You are all familiar with the morbidity of tunnel dialysis catheters, which is admission risk is higher, mortality is higher, venous occlusion, and we get paid, so we get paid to do dialysis by our providers less for tunnel dialysis catheter versus something on venous fistula or AVG1 dialysis. The difference is, so this is in pounds, 113 versus 141. It works out to £1,500 per year difference. So it is an incentive, not only from the ethical value of good care, but also from the monetary value as well. And it costs a lot as well when somebody has problems with the tunnel dialysis catheter. So we are incentivized to do that. The government thinks that's the right thing to do. However, more recently we may think we need to revise this, because this is actually guidance that's come out quite a while ago, almost like 8 years ago. So in my practice, we try to attain those and achieve those. And we had a very complex way of looking after patients in multiple specialities: vascular, radiology, nephrology, and also cardiology. And this, I don't want you to look at it in a lot of detail, but it just shows what my colleagues in this particular graphic and showing you the pathway of care between getting the fistula done and then actually having a good outcome. And people ending up with tunnel dialysis catheters, all the different people involved. The green is all that you want to look at. That's the nephrology involvement. At the beginning, a little bit in the middle. The rest is all here, which is vascular surgery and also radiology and patient time. And we looked at this paradigm almost 4 years ago and said we need to make a change, because we cannot go on like this. We're not achieving the targets that we are being set to do so. National data set drove the change as well. So this is, again, the 3 units were reversed. So there's 52 units in the country, and these are the 3 units in the northeast. And we were down here showing that our prevalence rate for tunnel dialysis catheters was higher than expected. We're supposed to reach, in an incidence population, 60% on fistula, and on a prevalent population of 85% on fistula. So we were not achieving that. Our incident population was 50% and our prevalence population was 65%. So we were below the national target. So what do we do? Well, we need to do something different. You know, we're all very busy, we don't have a lot of time to do things, but we have to do something. So we did something. In 2016, I took a team, myself, and one of my colleagues, Dr. Clark, who's in the audience. We went to the States. We had a look. We didn't think they were doing the best, but we thought maybe doing something different. And these 2 guys we met, who are doing dialysis access in an access center outside the hospital. So this is Tom Vesely and Steve Bander, 1 radiologist, 1 nephrologist. And that's their equipment. Nothing special. This is only just a portable system in a clinic on top of orthopedic sort of outpatients, but not in a hospital. That's all they had. We visited, and it's always good, and only when you connect with people, to visit in a team. You cannot make a change on your own. The most powerful driver in change in your department will be the nurse. And until you realize that, you will not be able to make a change, because they have great ownership of the patient. They have more close contact with the patient more than you. So we took our vascular access nurse. We took at that stage Rory, who was my junior doctor at that time, my registrar, and myself. And we had a little look around, and we decided that we wanted to follow a different model. We wanted to offer weekday consultant-delivered care, so not registrar-delivered, consultant-delivered care. Same on next-day assessment of any access issues. Improve and enlarge our ambulatory care centers so people are not admitted to the hospital. Develop a screening program, early start PD, you will be very familiar with those kind of things. Acute PD, and then increasing PD in heart failure, which is a common phenomenon in our patients as well. So how do we go about doing this? Well, we convinced our managers, because that's all is in the business case, to have fewer hospital admissions, fewer missed hemodialysis sessions due to lack of access, reduce pressure on the in-center hemodialysis program, reduce the reliance on tunnel dialysis catheters, fewer reroute adherence fistulas, and reduce the pressure. So we thought we could make a cost saving of £300,000 per year if we got the tariff right and we got the right patients into the right areas. So obviously the business people in our hospital bought into that. It took me 3 years to get them convinced. It wasn't a short journey. The whole journey is about 10 years, and this is a culmination of that. At the same time, when we thought about going to the States, this came out. Where a lot of you are familiar with NEFSAPS. This is a journal that is used for training, and there's some advanced training available. So we thought we'd tap into that. So we had a little visit. We learned a few little tricks. All of you do tunnel dialysis catheters, I'm pretty sure. But you do them the best way possible, and you learn probably from your registrar or your senior registrar. But are there really consultants who are teaching you, who are experts in that field? There weren't many in the UK, so we went to the States. Little trick. You put a tunnel dialysis catheter in. A lot of people are obese. They may have a pacemaker or something. You want to make sure that the skin is actually retracted back, so therefore you get good access to the veins. That's one thing. Veins vary. You need to have good equipment. We used to do these blindly. We've moved into obviously using ultrasound. But what is the best ultrasound machine? We looked at all three of these machines. All three of these machines. And this is the old machine I bought many years ago. That's 10 years old. These are the new models. They were too expensive. Couldn't afford them. Went for this model instead, which was half the price. And I really kicked myself. I shouldn't have gone for it because, as you all know, they got even cheaper. They're like this one. This is $2,000. I paid about $20,000 for my machine, and the expensive machines were $40,000. So it's not about affordability. I'm sure even in a developing country, $2,000 is much cheaper than many of the machines that you've got on your boards. So maybe we move to this technology. Then we learned how to do the tunnel dialysis catheter properly. We all thought we were doing it properly. We learned how to use fluoroscopy and learned a little bit of radiology with the Benson wire and the different French gauges that we use. And we learned position is very important. So putting the patient in the right position, the venotomy site that you make is important as well. And we've done that in some of the training we've done at PSM this week, which we'll show. And then determining the correct length. Honest to God, I was doing it for 10 years until we learned this. And I was now kicking myself that we should really be very accurate in where we place them. So we use techniques such as putting the wire down to the internal jugular vein, just measuring it by putting the wire down and making a little kink in the wire so we know where it is, and using little techniques where you can use fluoroscopy to bend the guide wire. So that's the position, and then we then size it. Once we've got the guide wire coming back out, then we know the exact catheter size. And why do you think it matters? Well, this particular paper, looking at where you place the catheter, SVC, the carina, right heart border, right mid zone, or the junction of the ventricle here, and also the SVC. So it actually matters where you place it, because if you place it in the ideal position, which is here, 245-day length of that catheter, that's how long it survives. Versus 12 days a year. You see them in ICU, they put them in all sorts of positions. We all go a bit berserk when they put the temporary catheter here, or maybe here. So if you're going to be meticulous, which many nephrologists are, which is a good thing, it's happy that we are doing this now. Honestly, I wish I knew this when I was a resident. I didn't, and it wasn't taught to me that way either. And we had to go back to learn the basics again. And safety matters. Depends if it is available, but we do majority, 95% of our catheters now under fluoroscopy. And no fluoroscopy is not available. We've done some cases in this country as well now. It's difficult. I tell you how we started. We started in cardiology labs out of hours. It's the passion that you have to get the extra hour that you can before they stop in the evening. And guess what? That was the same in the States 20 years ago, the same in the UK, and the same in this country. The migration, the evolution is always the same, but we're trying not to reinvent the wheel. So orientation at the tip of the catheter is important. So once you start with fluoroscopy, you can then look at the tip and make sure that's orientated correctly as well. Then you can do left-sided catheters. Do you think many of you will do this blindly? Left-sided, when this is what you're actually doing with a double lumen catheter, you can do a huge trocar down here. You can imagine the risk of causing a mediastinal tear. Has happened, we've seen it happen. You wouldn't find me doing it. So even from a safety point of view, if you cannot find the results, it is an impelling sort of evidence base to do that. Now, one thing we do different, and we've done on this occasion in Saeed Ahmed a couple of days ago is talk about replacing catheters, which we did on one case for fibrous sheath removal. And fibrous sheath develops within days, from here, days to weeks. So, and the reason is plasma proteins, platelets, thrombus, all those kind of things are all developed. So what to do? Well, you can replace the catheter, that's fine, but you put it back into the same sheath that you did before. And this is some histology. This is the catheter lumen, and you can see around it the sheath, and this is one thing you can see the sheath. It develops very quickly. So those placing catheters, it's easy to replace it, but you can't replace it back in the same fibrous sheath that you just been removed from, because you're actually not going to make the catheter live any longer than it did already. So what do? Well, we look at the catheter, we do some fluoroscopy images, and we start doing videography of these catheters as well. This is the pathology, develops in days, as you see from the lumen, and then migrates backwards towards the catheter itself. So now, when we replace the catheter, we pull the catheter back, and we do what we call pullback angio. So we put some contrast dye down. You can see here, there is a sheath there because it hasn't gone with a larger IUC. We would then go on to do a plasty of that. Yes, are we trained to do this? We have trained to do this. Are we radiologists? No, we're not. Is it safe? Safe as long as you know the risks that are involved. This is a large vessel. These are large rooms up to 10 millimeters wide, and therefore using the pressures that we use is pretty safe to do so. Yes, it's in the mediastinum. You need to know what you're doing and select the patients very carefully. But if you do that and then replace the catheter, so here, you can then say the flow is much better in the more of the IVC than before. So it's a simple thing to do, and it is easily done as well. So here we go. The catheter, if you have no sheath, 18 to 49 days, you put it back in with a sheath and no plastic, it's doing the 73 days. And you can see the difference between the two in this particular paper. So it's worth removing the sheath if you can. Clinical cost of venous catheter should all be placed in fluoroscopy. This is national guidance in the UK. Due to the risks that are involved, we have had fatalities as a result of this. And this is obviously been recognised nationally, so it's incumbent on every hospital to provide it. Here's a case really, and we managed to put a guide wire down here, we put a guide wire here. We didn't know where we were, we learned from that. This is going to the azygous thing. So you need to know your anatomy as juniors, you need to be taught that actually this is a straightforward IVC, but behind it is the azygous vein. And that sometimes is patent, and sometimes you get your wire down that. And if you're doing them blindly, you won't know you've done that. You may place the whole lumen of the catheter, not in this vein, in this vein here. And that can be quite large as the IVC due to central venous occlusion. So it's easily done. And that's the anatomy. This is where you want to be, but your wire can come down the jugular and then go sometimes flip back and go down. And look very similar on the chest x-ray, but it'll be a deviation to the midline. And that's worth knowing. And it's a lesson you learned as well. And here's the case. You've got complete occlusion here of the IVC. Occlusion there, and the zygous is quite large. You can see if you put a wire down here, sometimes it goes straight around. So if you remove that occlusion with angioplasty as we do here, then you open the IVC up and the azygous is not as patent as before. And that's worth doing. So here we have replaced the catheter back here and removed the occlusion. So central occlusion is common. You are using a lot of dialysis catheters, and as you 41% experience at least some sort of thrombosis with central occlusion leading to edema. And this is the risk. Those putting subclavians are causing 40% risk of subclavian stenosis, 20% on the right side, 40% on the left, and 60% if you use subclavian on the left. So right is the best to go, and then obviously we switch to the left. But subclavians are still there, and this is the risk you're putting your patients through of increasing thrombosis. And these are the kind of diagnoses, your nightmare situation of complete occlusion that you can get to if you don't work out where the occlusion is. So there is a total risk of that happening. The other thing is not all these dialysis catheters, we have techniques of peritoneal dialysis, so we talked about that a little bit. And here's different methods we do. We do a medical PV catheter, and we do not have an externalized catheter. We have a buried catheter to allow you to put them in preemptively in advance of needing dialysis, because you never know when you need it, because it's very difficult to predict the decline in GFR in these patients. That's the technique we've developed as well. So coming to conclusion, I'm moving where interventional nephrology is a patient advocate. You're in nephrology, you know your patients pretty well, but you need to bring a whole team of people with you. And with that, we managed to do this. So Dr. Clark, who was in my department, went back after 2016 to 2017 and retrained in the lab of Steve Van and Tom Besson, had spent time there, and then he came back to Cortisol. So here's one before the registrar teaching the consultant. That never happens usually, but here it happened. and we're happy for that. And then we changed the pathway, and now there's lots of green in that pathway where we're centrally involved in the patient's care. And yes, there is some vascular team, but they're all in the theatres doing the fistulas ourselves. But we have more control over the system of what's going on. And then we launched that from 2016. I can't do any of this on my own. This is where the collaboration comes. It started with me, then Dr. Clark, we had our vascular, now 2 more colleagues. Me and Dr. Clark are only here because my colleagues are doing all the work back home. You cannot leave your unit without support. I need to bring everybody along so they can also learn. This is a program we want to develop. So in the UK, we do not have interventional nephrology as a program, but this is what we are pushing through the curriculum. So if you're in nephrology training in the UK, you can become a consultant as long as you can put a temporary vascular catheter in. Not even renal biopsy, natal transplant is mandated. It's optional. All of this is optional. So where we are in Sunderland, we have developed a system that between us all, we do all of this. We offer this as to our patients, as patient-level care. We hope that people are interested to do at least stage 2 of training, which is orthopedic catheter insertion and dialysis catheter and ultrasound training as well. And as we launch those systems, many of you junior doctors need to follow us through that to provide the support for you and for us. So this is our Twitter feed for simulation training in vascular access and dialysis issues. And we train our nurses in simulation training in the acute situation. And this is our junior doctor training that we do, similar to the PSN workshop we did yesterday. Much smaller scale, but we use that to learn from here and teach here the other day. We did a lot of practicing before we came here. But we all make mistakes. Here's a mistake of mine I'm happy to share, and the patient survived. You'll notice here there's a catheter with a chest X-ray. There's a catheter, but there's no external bit, and the catheter is completely slipped into the IVC, the superior area in the heart. So you are stuck. This is catheter removal gone wrong. And it's one of my cases I did when I was junior, and I managed to remove the catheter. So we had to have the radiologist snare the catheter in the femoral vein. So you do need the help at times, but you need to know what to say. On the other side, collaboration. This is why we're here today. These are the journey from the West. These are some of the characters you will recognize. Arif Asif, who has visited our unit. This is my vascular surgeon. This is myself. We got him invited to give a talk to our radiologist. The radiologist learned from the nephrologist the kind of things we're doing. We then launched our team own, and here you see one of your local characters, Haroon, who's working in my department as a collaboration via PSN, and Sheikh Saeed, who's working here. And then turn the whole story back. We came to Sheikh Saeed only 2 days ago, and we're still cases here. You did it on the resources that are available to you. Your resources are no more than what we have back home in the UK. They're no more, but we managed to deliver it because we have great passion and belief in what we want to do. And yesterday, we did a very successful PSN. 6 stations. This has never been done in the UK. This will be now taken the other way, from the east to the west. We will learn from you. We've got some of the world's experts, in Professor Maria Richards from IXN, your local experts here who are interventional nephrologists from Saudi Arabia, from the UK as well. This has never happened and it should be celebrated. And I think this is publishable. And we will, I have the feedback from this, we will publish it either locally or internationally. And it has to be celebrated because we want to use it in the UK. Remember, the last question. Nephrology started with access. It was by nephrologists, not surgeons or radiologists. As you know, Brescia, first vascular fistula was done by here, Brescia, asking a surgeon to do a radical fistula. First arteriogram was also done by a nephrologist. So when we have this kickback from radiology and surgical, just remind them what the history is, where we came from. As the Chinese know, we say, you need to know where you come from, so that the journey can occur to where you're going to.